today we start off by talking about minerals which work as cofactors in metabolic reactions in general. They are different than coenzymes in the sense that coenzymes are in general organic, and so far you have seen how the various vitamins have very specific coenzyme forms. For example, thiamine, vitamin B1, functions as thiamine pyrophosphate or thiamine diphosphate in metabolic reactions. And with regard to coenzymes, what they do is that they help activate the enzyme to do its job. That's how they work. Whereas with cofactors, which are primarily inorganic and include primarily minerals, then minerals actually become a part of that enzyme structure itself. And you can look at how that happens with regard to the mineral that we are going to be talking about, and that is iron is what we are going to be talking about today. So once again, keeping in mind that form is equal to function, it's important to think about how we eat this mineral, that is, what form is it eaten in, and how is it converted or not converted as it's being absorbed, and then how is it used, in which form is it used as a cofactor for enzymes in various metabolic pathways. So let's start off then with the first slide, as we can see here. So in terms of the dietary forms of iron, in the diet, for example, can come from two different sources, and that would be in the form of either hemoglobin or myoglobin, and then also as just iron by itself. And for the most part, iron is present in the Fe+3 form, just as a mineral within the different types of food that we consume. Now, in general, the dietary iron is kind of divided into two categories. One is called as the heme iron, that is the iron that is part of the heme molecule, which also is part of hemoglobin. So essentially, when we eat animal-based foods, essentially meats, so those contain both hemoglobin, which is the molecule that carries oxygen to the lungs for exchange, and also myoglobin, which is a protein also that contains iron. It stores iron as well as helps with regard to muscle function. So that's why it's called as myoglobin. So when we eat food, then if you look at heme sources of iron, those would primarily be the ones that are coming from animal-based foods, especially with regard to red meats in general. Now, the non-heme iron, primarily that is in this form, it comes from plant-based foods. And for example, we all know that dark green leafy vegetables are rich sources of iron, and that would be in that ferric form in general. So if you look at both of these types of iron, then the heme iron is absorbed much better compared to the iron that comes from plant-based foods. And you can see the numbers right there. So non-heme iron is the predominant form of iron that most of us consume around the world, but its absorption is sort of low, anywhere from only 2 to 20%, whereas heme iron only comes from animal products. That means vegetarians don't consume much of this, but its absorption is much better than that of non-heme iron, and it's around 15 to about 35%. And another important thing is that absorption of iron is directly, inversely related to the amount that we consume in our diet. In other words, as the amount of the dietary iron increases, its absorption decreases. On the other hand, if you are consuming too much iron, then the absorption of the iron, regardless of which type it is going to be decreased. So the concept here is that the important thing to keep in mind is that the body then keeps iron absorption and then subsequent metabolism in very tight control, because having excessive iron sitting within the cytosol of any cell can promote free radical mediated damage. So it's very much contained and used in a very appropriate way, so to speak. So moving on, and you can see here, as a matter of fact, that there are certain factors that both help with the dietary iron absorption, and the factors that help, there's a long list of them, and the first one is ascorbic acid. This is a very important consideration in terms of counseling both young women especially. So women are more at risk for developing iron deficiency anemia, or in other words also just having suboptimal iron stores, because they have menstrual loss of iron through the loss of blood every month. That's a problem. But also, if you were to really look at it worldwide, iron is the micronutrient that is usually is actually the primary nutrient that's consumed in suboptimal levels all over the world, including this country. So, for example, for vegetarians then, if vitamin C helps the absorption of iron, then it's important that when you're counseling patients, then to make sure, for example, in this country especially, because all grains are fortified with iron. So if somebody is eating cereal in the morning, and since that cereal has iron, it's important for them to perhaps have that with a small glass of orange juice, so that vitamin C in that orange juice will help the absorption of that iron, which is in this form. So that's an important concept to keep in mind. And also inhibitors, if you notice, for the most part are oxalic acid, phytates and all of that are present primarily in fiber rich foods. And keep in mind, in general, we recommend higher intakes of fiber, but also keep in mind that they also contain inhibitors that may decrease the absorption of iron in general. When are we likely to have kind of a low iron status? What endogenous factors would influence that? Endogenous factors that would promote iron use in general would be whenever there is enhanced erythropoiesis, that is the making of red blood cells, which is induced under conditions of hypoxia, hemorrhage. So in other words, if you had a bleeding episode, then your body automatically tries to replace those red blood cells, and that's when iron usage, actually iron absorption also actually increases in order to sustain that production of the red blood cells as well. And then on the other hand, if you have an infection or inflammation, then that would actually decrease the absorption of iron, and I'll explain that a little bit more later on. Along with having lack of now stomach acid, it's called achlorhydria, and it's likely to happen in the elderly. So the presence of HCl is required to keep iron in the right oxidized form in order for it to be absorbed in the duodenum. So from that point of view, not having enough hydrochloric acid is also an issue with regard to the absorption of iron. So most iron in the body is in the form of heme, and on this slide you can actually see the structure of heme. Heme is part of hemoglobin, but the heme structure in and of itself, if you notice, there is an iron right in the middle of this heme structure. The heme is present in many different proteins. And as being a part of that protein, let's say that protein functions as an enzyme, then iron plays an important role, obviously, with regard to the function of that enzyme. The second largest pool in the body is ferritin. That's the storage form of iron that is seen, usually present in the cytosol. But under certain circumstances, there is too much ferritin that's deposited inside the cells along with some other molecules, and then that's called as hemosiderin, and once you build that up, then the ferritin becomes unavailable. So it's not a good thing to have a buildup of hemosiderin, but otherwise ferritin is the storage form of iron. So and then transferrin is the protein that transfers iron throughout the circulation. So let's look at what happens with regard to intestinal absorption of iron, and here there are a lot of terms that we'll be looking at in just a minute. And this is a really great video for you to see. I recommend that you do that, but let me go ahead and talk a little bit about the digestion and absorption of iron in general, and keeping in mind that when you consume iron, I've already told you that you can either consume it in this form or in this form in general. So if you were to pretend that this is the intestinal lumen and we have the mucosa right here, then that which extends out as a villus, and on the tip of the villus is, or along the villus axis, we do have enterocytes with the brush border that we've talked about in the past as well. And from inside the lamina propria of the villus, we have circulation in the sense of having capillaries that end up becoming then the mesenteric capillaries or mesenteric arteries, which end up ultimately going to the liver. So in terms of iron, so let's actually go ahead and draw the liver over here, so we can talk about it in kind of more detail. So through the portal vein, then iron gets into this part. So first of all, then let's talk about the iron that we consume as hemoglobin and myoglobin. So what happens is within the intestinal tract, there is not a whole lot of breakdown or anything like that, but it's been shown that the heme iron that is consumed, so the globin, which is sort of like the protein part of hemoglobin, globin can be denatured in the gastric mucosa because of the HCl without any doubt at all. But it's been shown that apparently there are transporters that transport hemoglobin intact into the enterocyte, and then that there are other transporters that can take that heme and then put it across the basal membrane into the circulation and on up into the liver. It looks like this is an area of research that continues to happen, and your textbook talks about the roles of different types of proteins that they're still trying to figure out with regard to the uptake of heme by the intestinal enterocyte, and how then it exactly leaves the enterocyte and makes it into the circulation and on up into the liver. On the other hand, if you were to consume the plant-based iron, which is in this form, and iron exists in two different forms. One is called as ferric and ferrous irons. So this is Fe+2, which is called as the ferrous form, and then there is what is called as ferric iron +3, and then there are enzyme called as ferrireductases that convert the ferrous iron into the ferric iron in general. So when we consume the ferric form of the iron within the diet, then essentially what happens is that the ferrireductase, that cannot be correct, can it? The other way around. So let's see. Oh, I'm also writing it more closer to that. So we
It's
can
not
just.
It's not cut off on the other.
Oh, okay. Great, great, great. Let me redo this part, so
Okay.
we can just eliminate it, and then I'll keep moving. Okay.
Now, I will say there are times when you're underneath, like right now, you're underneath your PowerPoint. Sometimes
Yeah,
you
because the
can enter your
PowerPoint is
movie.
bigger, right?
Yeah.
Yeah, but I think overall, if I'm continuing to
Right.
do that, it may look that way, but it's okay. I
Okay.
think for a class, you
Okay.
know, it's
Just since
fine.
we stopped, I thought I mentioned
Okay, sure, sure,
Okay.
sure. No worries, no worries.
Okay, whenever you're ready.
Okay, thank you. So iron in its ionized form is present in two different forms. One is called as you can see right here, as ferrous or ferric. Ferrous is the Fe+2 form, and then ferric is Fe+3. So, and there are enzymes that convert the FeRrOUS form to IC form, and these are called as FeRRI, okay, ferrireductases. Okay. So after keeping that in your mind, then when we consume the food and the iron is in the form of Fe3+, however, the iron in the Fe3+ form cannot really cross the intestinal membrane. So as a result of that, what actually happens is that there are So, here is the enterocyte. So, when the iron actually shows up here as Fe plus 3, then there is a ferrireductase that is actually present in, I am going to go back and correct this. So, it is a reductase, so it has to go from Fe3 to actually Fe2, and I apologize for that. So, this would be the ferric form and this would be the ferrous form. Oh, Mira. I have to go back again. So, iron is present in two forms, either as ferrous or ferric iron, as you can see on the slide. So, the ferric iron is Fe plus 3, that is the more oxidized form of the iron. Fe plus 3 is ferric iron, and this can be converted to Fe plus 2 or ferrous iron by FeRRI reductases. Okay. So, going back to looking at when we have eaten a meal that contains plant based foods. So, the iron is in there is in the ferric form. One of the issues is that we have the iron present in this form right within the duodenal area, and for this iron is not actually taken up in this form into the enterocyte, it has to be in the ferrous form for it to be taken up. So, there are two proteins here that play an important role in that change or modulation. There is one type of a protein right here that has the ability to act as a ferrireductase, and so it converts Fe3 plus to Fe plus 2. Once it is in this form, the ferrous form, then the iron then can be taken up by a divalent mineral transporter 1, that is the transporter right here, and then Fe2 plus goes back in here, and now you have it in this form sitting in the cytoplasm. Now, what can happen within the enterocyte is that then this can actually join the protein like ferritin, which is essentially a protein that is capable of kind of huddling and capturing quite a bit of these iron and keeping them together, so to speak. That is what the ferritin protein, or the ferritin is the storage form of iron. So, this can then become part of ferritin right here. And another thing that can possibly happen is that the efflux or the bringing out of the iron into the circulation, then the way in which that happens is that once again there is a protein by the name of ferroportin, which is responsible for iron efflux. And what you need to remember is that the ferroportin is also present on liver cells without any doubt at all, so that it can be used for the efflux of iron from the liver cells without any doubt at all. And what happens is that once ferroportin ferroportin, through ferroportin, we take the iron and put it out here, and essentially the iron crosses ferroportin and ends up in the circulation being bound to transferrin. So the ferrous form of the iron is transported by the divalent metal transporter into the cytoplasm, and here it can be converted again, I think, into Fe+3 and stored in ferritin. Ferritin is nothing but a complex that contains a bunch of proteins that kind of sequester this kind of iron and keep it kind of closed off and not available to the other organelles or molecules, because this is where what I talked about earlier on is the fact that through two different types of reactions called Haber-Weiss as well as Fenton reactions, it is possible for iron to actually act as a generator of free radicals. And once that free radicals are generated, if you don't have enough antioxidant defense, then you're looking at increased oxidative stress overall, and that is the reason iron presence both inside the cell as well as the outside of the cell is kind of regulated very closely. So then iron actually ends up leaving the enterocyte through the help of a protein then called ferroportin is the name of this, ferroportin. And as a result of this, you end up seeing iron come out as Fe+3, but in general, the form in which iron is present in most of the heme components as well as the biologically active form of iron would actually then be Fe+2. So this Fe+3 here is converted by another protein or an enzyme called hephaestin back to Fe+2, and now this is how iron shows up in the circulation. And once it's in the circulation, Fe+2 is then bound by or bound to transferrin. That's how it circulates in the plasma, and then ultimately this complex is recognized by any cell that has what is called as a transferrin receptor. So this entire complex then binds to this, and then the whole thing is engulfed into the cell, and then that is where iron is then released or made and or becomes a part of various enzyme structures, so to speak. So if you are looking at the biological significance or what are the functions of iron, then iron participates essentially in a wide variety of biochemical reactions, but it is used in different forms. The first one that you see is that many proteins, for example, isocitrate dehydrogenase as well as succinate dehydrogenase, you should recognize these as being enzymes that participate in the Krebs citric acid cycle, and both of these enzymes along with other types actually have an iron and the sulfur in the middle of their structure, and that helps that protein. Whenever we talk about iron being a part of the protein structure, then the idea is that it is held in such a way that gives that conformation to that protein so that the protein can actually then function properly. So that's one way in which iron is impossible. Number two, now iron in the form of heme or heme enzymes also participate in electron transport. So if you look at the electron transport chain, not just on the electron transport chain, but also others, but on the electron transport chain you have cytochrome B, which is one of the units that is capable of taking up the electrons and transferring them. And what's actually doing is that what's actually happening is it is the heme that, as a part of that particular cytochrome B, is helping the transfer of that electron. So that's another function of iron. And then, of course, if you look at the globin, heme, that is, heme as a part of hemoglobin is absolutely essential for the transfer of oxygen to all of the cells in general, being able to pick up oxygen from the lungs and then be able to transport it to all the cells. And then finally, there are also enzymes that contain iron by itself, but is used as a cofactor in the propagation of a reaction. For example, if you were to take phenylalanine hydroxylase, this is the enzyme that converts phenylalanine to tyrosine. So the requirement for iron, so it perhaps comes closer to this enzyme and becomes a part of it, even if it's temporary, to be able to promote that enzymatic reaction by which we end up forming the other non-essential amino acid, which is tyrosine. And then the other two examples that you see there, tyrosine hydroxylase as well as 5-hydroxytryptophan hydroxylase, are enzymes that are again very important in creating the neurochemical dopamine. So essentially, iron as a part, or iron in the form of heme, are parts of enzymes that promote a lot of different biochemical pathways within the body. Now, your textbook talks about regulation of iron status at the cellular level as it relates to biological activity. And so there is a very tight regulation of how much iron is actually possible, and this regulation happens by either increasing or decreasing the expression of iron transporters, which would be DMT1 and ferroportin, or iron storing things such as, for example, the presence of ferritin, which actually stores iron. And so if you were to take a look at this table in your textbook, it gives you some idea of how this happens, but this figure actually explains it much better. So in general, if you were to take a quick look at this, and I'm going to just focus on, so if you look at the slide, I'm focusing on that side of the slide, so that will be my left part of the slide. And if there is a lower amount of iron in a cell, so this regulation has to do with how iron levels are managed between and within cells. That's all we are talking about, between cells and within cells as well. So in order to promote this, you need two things. Number one is they're referred to as iron regulatory proteins, or IRPs is one of them. And the other terminology that you need to know are iron response elements. Iron response elements. Now, what are these? How do they exist in general? So if you were to take any cell at all, whenever you have to make a protein, you have to go through transcription and then through translation. So if you were to take a look at that, transcription meaning you take DNA and through transcription you make mRNA. All of this happens in the nucleus. Then the mRNA comes out into the cytoplasm, and then, so this is transcription, CRIPT, and this would be translation. And then from that mRNA, through translation, which happens on the ribosomes, you're actually making that particular protein of interest. Now, I just mentioned a few minutes ago that DMT1 as well as ferroportin, as well as transferrin, transferrin receptor, ferritin, all of these are proteins that have to be made. So, whether the iron is actually going to be absorbed and taken up into cells, or if iron absorption is going to be kind of reduced, depends on absolutely the expression of that protein, which has to go through this entire process. Now, the thing is so what happens is that every cell has these iron regulatory proteins in general, and what happens is within a cell, for example, they exist, they're there by themselves in general. Okay. So, under low iron status, then the iron regulatory proteins are actually not bound to iron in general. So, they're free and available, and what they do then is then they go and bind to the iron response elements on the mRNA of either transferrin, or whether it is ferroportin or one of the proteins. And how does this regulation actually happen? So, if you look at mRNA, the way in which we draw out an mRNA molecule is that it could go all the way from 5' all the way to 3'. So, in this figure, what they're trying to show you is under low iron circumstances, because there is not enough iron to bind to this iron regulatory protein, then it goes ahead and actually goes to the mRNA of either the transporters, that would be the transferrin receptor or either the DMT1, and this would happen on the 3'. So, these then go and bind. When we talk about the 3' end, they are going to go and bind right here, and they will stabilize that mRNA, and as a result of that stabilization of the mRNA, you're likely to make more of that protein. And this happens with regard to both the transferrin receptor as well as DMT1. Now, think about that for just a second. So, one way in which iron uptake can be regulated is that if you have low iron, then the goal should be that you increase the amount of iron in a cell. So, under low iron circumstances, these iron regulatory proteins will go and sit on the 3' end of the mRNA of DMT1, which is the function of which is to be able to take in iron, as well as the transferrin receptor, which also takes in iron. And by sitting there, they're increasing the expression. By stabilizing the mRNA, you have a greater amount of these proteins, which are then able to take up more iron into the cell, and so you resolve the problem at that point in time. Another way in which this can also be regulated is that the same concept also holds true, but if these iron regulatory proteins can also bind to the 5' end when there is too much iron in the cell, but if they bind to the 5' end of ferritin and ferroprotein. So what would happen then? You would express more of the ferritin and the ferroprotein, meaning you are going to sequester more of the iron within the cell and also be able to absorb more iron from the intestinal tract as well, and then for it to be able to be used or sequestered in a way. So that's what I'm talking about. So this is one way in which iron, the amount of iron in terms of whether it's going to be taken up into the cells versus it's going to stay in the storage form is regulated within the body. Another way, another protein that is important that ends up regulating iron status has to do with one protein called hepcidin, and this protein is primarily produced in the liver. So liver is the one that produces this particular protein, and the question then becomes, under what circumstances is hepcidin produced and what does it do is the question. So the function of if you can look at this slide, what you're actually going to notice is under low hepcidin concentrations, as the slide suggests, iron is exported via ferroportin into the extracellular space. That means there is more iron that is available for uptake into liver cells as well as red blood cells, as you can see on this particular slide on my right hand side of the slide. And under conditions where there are high hepcidin concentrations, then essentially ferroportin is degraded and iron accumulates intracellularly as well. So you have to then think about under what conditions are hepcidin levels regulated. For example, they say under conditions of infections, hepcidin levels might be increased, and as a result of this, there is more of a condition of being able to sequester or store iron. They say that bacteria in general actually require iron to be able to divide and multiply, and under conditions of infection, if you are able to then sequester iron in certain places and not make it available in the extracellular space, then that somehow helps diminish the strength of that infection, so to speak. In other words, you're depriving the bacteria of the iron that they need to be able to promote the infection. You can take a look at the recommended dietary allowances in general, just in your textbook, as this table suggests in table 10.2. And then in terms of iron intake overall, I've already mentioned this. If you look at it globally, iron is one of the, not one of the main mineral that is consumed, or rather overall in the world globally, there is a low iron status among people in general. And this is all the more true, especially in infants and especially in women of childbearing age, including this country. And part of the reason for that is around the world, wherever people subsist on vegetarian diets, once again, the high amounts of phytates and fiber in the diet reduces the absorption of iron without any doubt at all. Gastric acidity, you have to have enough of an acidic environment to make sure that you're able to keep the iron in the right form for it to be able to be absorbed. And then heme iron, like I said before, if you're able to consume red meats, then you should be able to better absorb the iron that's available. Breast milk is a very poor source of iron in general. However, when baby is born, the baby actually has a certain amount of iron storage with which it is born. So it's okay for the baby. It lasts, those stored iron levels last for about maybe 3 to 6 months at the most. And that is the reason one of the first foods that are introduced to the baby are in general, well, beyond that, the first food that's introduced to the babies are usually cereal, because it's easier to digest for that reason. However, the cereals in this country are fortified with iron, and from that point of view, then they're more likely to get the iron from the cereal. So for an exclusively breastfed baby, their intake of iron is kind of on the lower end. However, they have enough stores for a little period of time. But however, if the baby is fed infant formula, almost all infant formulas are fortified with iron, so they should get enough iron just from drinking the infant formula. And then ultimately at the bottom we are talking about why do the following groups need special consideration while estimating dietary iron requirements. Endurance athletes, think about that a little bit, as well as vegetarians, and then intestinal parasite infection. I think these are conditions that you can kind of figure out based on what we've talked about so far. Now, with regard to iron deficiency and how it is actually measured, if you were to take a look at it, so they look at several things to assess iron status. Keep in mind that suboptimal iron status is not the same as having frank anemia. So with full iron deficiency, one ends up with what's called as a microcytic anemia. But going from suboptimal iron levels for the anemia to actually develop, so there is a bit of a, it takes, there's a difference between the two. So what is being actually used to then assess this would then depend on the types of tests that they actually do. In general, they can look at serum iron, transferrin, and then transferrin saturation, and the other tests that you see there as well. Besides these, they also look at the size of the red blood cell, the mean corpuscular volume of the red blood cell. Not only that, how much hemoglobin it contains would be another one. If in the first stages of iron deficiency, you have a tendency to see low hemoglobin levels. This is an easy test to conduct all over the world. All you need is a small drop of blood. And in women, if the hemoglobin level is less than 12, and in men, if the hemoglobin level is less than 13 milligrams per deciliter, then it's considered then that person is considered as being suboptimal in their iron status, and that they may be going more towards anemia. And usually at this point in time, iron supplements are given, but iron supplements are poorly tolerated by most people, primarily because they promote constipation in general. And so compliance with taking iron supplements is not that great. Now, one last point I want to make before I close up, and that has to do with hemochromatosis. This is a condition, and sometimes it can either be genetic or not, but the genetic condition arises because of a change or sort of like a polymorphism in this epsidin gene, and as a result of that, there is a tendency to store iron inappropriately in large amounts within the cells to a level where it promotes toxicity in general.